Hello, good morning everyone. I'm Sanchis, professor at Universitat of Valencia. And first of all, I apologize for my English, it's not my mother tongue, but I hope that everyone can understand what I want to say. I would like to thank the scientific committee for inviting to me in a EMPODE Congress. It's a huge honor for me to be able as opponent in this Congress. Today I'm going to talk about we study the dynamic stiffness joint of foot joints during walking. And we will attempt to outline how we believe could be implemented in the clinical practice. It's important to say that the most of kinetic studies performed in biomechanical laboratories have been limited in their application clinic. This problem has remained over the years in the history of biomechanics, and the problem is the difficult interpretation of the physical and languages mathematics. These data are not intuitive for the most of health professionals, and this application is usually delayed. For this reason, this presentation tries to describe the evolution of our group in analyzing of the stiffness, dynamic stiffness joint during walking, and attempt to guide towards its use in a clinical. In clinical practice, it's common that we perform different tests, Dannenberg or Silverskio's tests, to assess the motion of the foot. But the problem is that we don't evaluate the force acting in the foot when we perform this test. And this problem it's important because according to several authors, it appears that the foot injuries are not so much produced by abnormal movements, but either abnormal forces acting on the structural components on the lower limb and the foot, bones, ligaments, cartilage, and muscles. For the reasons, since we began our investigation on the foot, we want to study the effect of the forces acting on the foot, both roach joint moments and the stiffness joint. What do we study? Well, in our biomechanical laboratory, we have a Vicon system, we have a H-camera Vicon, and with this system we can study the kinematic. We can calculate joint angles. And we use a model proposed by Moreno, which considers 4 segments: shank, rear foot, forefoot, and hallux, and 3 joints: ankle, mid-tarsal, and metatarsophalangeal joints. With this setup, we can study the kinematic. On the other hand, we study the kinetic with use the pressure platform. It's important to say that nowadays in our laboratory we can 2 platforms: forces platform and pressure platform. And we are working using both simultaneously. Using the pressure platform, we can calculate the joint moments. What is the joint moments? The joint moment is defined by the product of the forces applied by the minimum distance, applied by joint by the minimum distance to the joint center. And the units are newtons by meter. With the data from kinematic study, the joint angles, and the data from kinetic study, joint moments, we can now we can analyze the stiffness joint. What is the stiffness joint? Well, From biomechanical perspective, the term of the stiffness joint is defined as the ratio between the external moment applied to the joint and the joint angle at a specific angle. There are two types of the stiffness. The passive stiffness is the stiffness assessed without a muscle contraction. This assessed corresponds to the storage potential energy by the formation of soft tissues around the joint. On the other hand, we have the dynamic stiffness, all named quasi-stiffness. His stiffness is assessed when the subject performs weight-bearing activities such as jumping, running, or walking. This stiffness combines the effect of the muscles, the effect of the inertia, and the deformation of the soft tissues. This stiffness can be used to joint stability indicator, and this stiffness is what we study. Well, what is dynamic joint stiffness? It's a quantifiable mechanic property that is used to characterize the natural spring-like function of the foot joint during the stem phase of gait. It's defined by the opposition to the joint moment in a particular direction when external forces is applied to this joint. It's calculated as a slope of the graph of moment versus angles. I can see an example. I can see a graph where the angles are the x-axis and the moments are in the y-axis. We can identify a phase with a linear relation between moments and joints, and we calculate the slope of this phase. The values of the slope is the values of the stiffness. Well, the dynamic stiffness have been proposed in several previous research with several purposes. To evaluate effect of surgery for arthroplasty of femoroacetabular impingement, to characterize the ankle's spring-like behavior, to predict the progression of the joint disease such as knee osteoarthritis, to improve the development of prosthesis and orthosis, and analyze the relationship between dynamic joint stiffness with gait speed, mechanical work, and anthropometry and gender. However, all of these studies have studied the ankle, the hip, and the knee joints, but nowadays the study of the dynamic joint stiffness of foot joints remains limited. Okay? We have proposed several studies for analyze the behavior mechanical the foot joints using a stiffness. In this study published in the JAMA, we characterize the behavior of the foot joints during normal walking through analysis of the dynamic of ankle, mid-tarsal, and metatarsophalangeal joint. In the paper, the first step, we plotted the graph of the rotation and the graph of the moment. After that, we plotted the graph, the angles versus moments, and we identify different phases for each joint. At the ankle, we identify 3 phases with relation linear, and we calculate the stiffness in these phases. In this joint, the phase 2 has a height dispersion, and we propose the study the ankle considered 2 phases. At mid-tarsal joint, we identify 3 phases, and the metatarsophalangeal joint, we identify only 1 phase correspond to the propulsive phase. In the paper, we try to describe the the behavior, the mechanical behavior in each phase for each joint. Try give interpretation, clinical interpretation. Once we describe the technical for calculation the stiffness, we want to study the variability intra-inter session and intra-inter participant, and we want to study the effect of the gait speed. This study have two experiments. In experiment one, I want to study the variability. 5 subjects walks 5 times with normal FPI, foot posture index, on 3 different days. And the experiment 2, 5 subjects with normal FPI walk 5 trials at 3 different speeds: normal, slow, and fast speed. What do we find? Well, in the experiment 1, I can see that the error repeatability intra-session and the error repeatability intra-session are very similar, and the standard deviation intra-session was higher than the standard deviation intra-session. This fact can be explained that the 5 trials are a good number of trials for analysis or study the gait. And in experiment 2, where we study the effect of the velocity, we found that generally when the speed is greater, the stiffness increase. This phenomenon particularly is notifiable in mid-tarsal joint. This fact can explain by an active motor of the stiffness to try avoid the collapse of the medial longitudinal arch when during the gait. With the technical to study the stiffness described and analyze the variability and the speed gait, we want to analyze the effect of the foot posture on the stiffness. This study has been concerned on 70 subjects. These subjects were classified using the foot posture index, and we have 30 normal foot, 20 high-like pronated foot, and 20 high-like supinated foot. In the paper, the analysis include the comparison of the room, the comparison of the moment range, and the effect of the stiffness. How this presentation focus in results of the stiffness, I show the graph of the stiffness. I can see the graph of each foot and each joint: ankle, mid-tarsal, and metatarsophalangeal joint. If we talk about network is the area within the graph. I can see that the normal foot have a smallest area. That means that this foot are the best balanced or equilibrated. And however, the pronated foot have a biggest area that they have absorbed more work, and then they make to susceptibility to injuries. If we talk about the values of the stiffness, we found that the pronated feet had a higher stiffness in propulsive phase. This can be explained by the lower capacity of the concentric contraction of the plantar flexion muscles during the propulsive phase. In the literature, muscle weakness is often described as a loss of stiffness in pronated foot, but strictly speak, opposite is true. In any case, this affect a normal gait in this foot during propulsion, in particular in activities where they require more propulsion, such as jumping or stairs climbing. All of these studies have been conducted with the subject in barefoot condition, but this fact is common in biomechanical studies, but the humans walks in shoe condition, and our purpose is analyzing the gait with the subject using footwear. But what problems do we have with analyze the subjects wearing footwear? Two problems. The markers placement of the shoes. When the subject wearing footwear is more difficult to identify the anatomical points where the markers are located. And when the subject walks, there is a foot motion inside the shoes, and there is a shoe deformation. And the other problem is we have to consider the ground reactive forces regarding on the foot or regarding on the footwear. If we consider the forces acting on the foot, we can use an insu pressure sensors. This device has advantages that we can segment the forces of each segment of the foot, but this device lacks friction forces, mediolateral or anteroposterior. If we consider the forces acting on the footwear, we can use force platform. The force platform don't have a friction forces, but if we use this device, we can segment the forces in each segment of the foot. We to use a pressure platform, and the pressure platform in the device we can segment the forces, but this device lacks friction forces. We are working in finding a solution to this problem, and we have already published a preliminary study. In this study published the last year, we want to address the difficulty of recording contact forces with the available sensors. 10 subjects, healthy subjects with a normal foot posture index, walks wearing two types of foot, a flexible foot and rigid foot, and we recorded the pressure platform using simultaneously two devices, instrumented insoles and the pressure platform. Okay. If we see the graph, the left graph is the pressure platform, and the right graph is the insole pressure sensor. We can see that the profile of the curves are very similar. If we compare the values of the peak moments with the values of the peak moments in another studies which use a force platform in barefoot, we can see that these values are lower than the another studies, and we think that this fact is for that we don't consider the friction forces. If we compare two types of foot, we can see that the flexible shoes has a slow peak moments for a frontal plane inversion and inversion at the mid-tarsal and metatarsophalangeal joint. This is important because we have precaution when we compare studies with using different footwears, but the footwear can affect it to calculate the moment. If we compare both devices, pressure platform versus insole pressure sensors or instrumented insoles, we don't find a difference in peaks moments, but there are differences in timing of peaks. The insole pressure sensor have a later peak moments during the stem phase. Finally, the device sent it to affect both the considered show conditions in the same way. These findings suggest the interchangeability of measuring job moments with one or another device independently of footwear condition. Well, to order make the calculation stiffness valuable in a clinical, several devices would be necessary. We want to record it pressure, and we can record it using two devices, or pressure platform or insole pressure sensors. Both devices are equality reliable. And study the kinematic study or study the motion, we can use the IMUS inertial measuring units. This device consists of three components: accelerometer to obtain the velocity, a magnetometer to obtain the position, and the gyroscope to obtain the rotation. This device have been used in lower limb studies for studying motion, and this device can be used and study the motion of the foot joints. Well, this device is cheaper than the 3D system, is easier post-acquisition, and is faster post-processing. Well, and finally, the last point and very important point is the friction model. For can calculate the stiffness in the clinical, it's necessary to have a friction model. With this friction model, we can calculate the friction forces based plantar pressures. This is crucial. And knowing relative velocity, and knowing kinematic model, and knowing coefficient friction, the friction model should be developed to obtain the friction forces. If we considering these devices and this friction model, we can use the stiffness joint in a clinical setting. Finally, to conclude, I would like to add that it's important to study forces, as they seem to be the cause of injuries in the lower limb. In order to bring research results closer to clinical practice, gaits should be studied while wearing shoes. And in the future, in order to analyze the effect of forces and study joint stiffness, it could be necessary in clinical setting to have a system to measure forces, whether instrumented in sole or pressure platform, along with a motion analysis and friction model. Thank you very much for your attention.
Thank you, Kike. We have time for one question. So I'm just looking in amphitheater 2 if there are questions. So Joe, maybe if you can join us and see if there are some questions in your room.
Hello. Yes, here. Any question here? Perfect. No questions?
Thank you. So,
On a une question chez nous.
Yes, we have a question.
We have a question.
Just tell them.
they have one.
Test.
Est-ce que vous pouvez développer un peu vos...
Can you develop your conclusion, please? Notably with respect to the fact that the pressures can create injuries. And I'm sorry, the interpreters are getting an echo.
To the conclusion slide. In your conclusion slide, you mentioned that, well, there is potentially a benefit to link your pressure data with other data. So could you give a little bit more information on that?
Estamos traducindo the chant.
Did you get the question, Kiki?
Yes,
or,
we are translating. We
okay,
are
no problem.
translating for him.
We are using the data of pressure platform for calculate joint moment. And this we can calculate the stiffness joint.
Okay, so the purpose I think here is that in the future you would like to have a correlation between your pressure data collected in shoe and try to validate that for your joint moments, I guess.
Yeah.
Yeah, I think it's in that direction. Yeah.
Yes.
Okay. All right. Thank you, Kike, for this intervention. Really appreciate it. The next presenter will be Priscila Távara-Vidalón. And she's from the University of Seville in Spain. She will be presenting a topic on the range of motion of the first ray in patients with Hallux limitus.
Good morning. I would like to thank the organization for providing me the opportunity to present this research, range of motion of the first ray in patients with Hallux limitus. Hallux limitus or Hallux rigidus is a disorder in general and athletic population. Hallux rigidus is the most common degenerative arthritis of the foot and is the second most common complaint in the great toe next to Hallux valgus. Patients may develop Hallux rigidus usually from repetitive trauma over a period of time or after an injury. Athletes with Hallux rigidus often report pain with explosive movements, in particular sprinting, jumping, or pivoting. Pain also be present, especially in runners with increasing distance and speeds. Hallux limitus consists when the base of the proximal phalanx of the hallux is subluxed in a plantar way over the head of the first metatarsal. Also is an alteration which goes along with the limitation of the first metatarsal phalangeal range of motion in the sagittal plane. It's accepted that for Hallux limitus to exist, this range of motion has to be less than 60 to 65 degrees. There are several pathomechanical and morphological factors that decreasing this range of motion. Some authors mention that the main cause of Hallux limitus is the metatarsus primus elevatus. And there are others who say that the elevation higher than 5 millimeters appears in 2/3 of normal feet. So it's not pathological entity and it's not correlated with the articular affectation. Because of this controversy, a direct relationship in presenting dorsiflexed first ray when one has Hallux limitus, and because there are few studies on the quantification of first ray range of motion in patients with Hallux limitus, the objective of this study was to determine the first ray range of motion in the sagittal plane in Hallux limitus patients and to compare it with normal feet. Another objective was to describe the relationship between the dorsiflexion between the metatarsophalangeal dorsiflexion and first ray mobility. This is a descriptive study that compared the range of motion of the first ray and the mobility of the first metatarsophalangeal joint in a group with Hallux limitus and a group with normal feet. Patients who participated in this study were adults who attend to a clinic, to a private clinic. The sample consists of 30 patients or 30 feet. 15 were part of the study group and 15 were part of the control group. 11 left feet and 19 right feet were included, and there were 17 men and 13 women. For the Hallux limitus group, the inclusion criterion was to have less than 60 degrees of dorsiflexion. And the exclusion criteria were to have experienced any traumatism or surgical intervention of the first ray, to present Hallux Valgus, to have suffered inflammatory or metabolic processes, degenerative or neuromuscular illnesses that affect the foot. The control group was patients with normal feet, with a first ray without any morphologic or functional alterations. The inclusion criteria were to present a normal first ray mobility and dorsiflexion greater than 60 degrees. The exclusion criteria were the same as the study group. The evaluation of the mobility of the first metatarsophalangeal joint was conducted with a goniometer. And the mobility of the first ray was measured with a first ray device. The head of the first metatarsal was moved upward to its maximum range in dorsiflexion and then moved downward to its maximum range in plantar flexion. In the data analysis, we used the Shapiro-Wilk test, the student test, and the Mann-Whitney-U test. Pearson correlation coefficient was used to determine the relation between the metatarsophalangeal dorsiflexion and range of motion of the first ray. The main aim of this study was to determine the first ray range of motion in the sagittal plane in Hallux limitus patients and normal patients. The dorsiflexion of the first ray in feet with Hallux limitus was increased, unlike the control group. On the contrary, the Hallux limitus group's plantar flexion diminished, unlike the control group. However, the total motion of the first ray was very similar in both groups. The controversy around the role of the metatarsus primus elevatus in the development of Hallux limitus exists. It has been found that some authors mention that it can be a factor in the pathogenesis of Hallux limitus, and some believe it cannot. Meyer and Horton analyzed radiographies in weight-bearing conditions, comparing the elevation of the first metatarsal with the second. And the results showed that the values in patients with mild or moderate Hallux rigidus were almost identical to the control group. These authors indicated that an average of 5 to 8 millimeters was a normal finding in both groups. On the contrary, Grady observed that patients with Hallux limitus present metatarsus primus elevatus as etiological factor. And there are others that reveal that there was more presence of metatarsus primus elevatus in the Hallux rigidus group than in a control group. When the authors studied the dorsiflexion of the first ray, they did it by a radiographic valuation. Unlike our study, in which we did a clinical examination with a device of the first ray. This is why it's very hard to compare our results with them. Another objective was to describe the relationship between the metatarsophalangeal dorsiflexion and the first ray mobility. We have not found studies that relate the plantar flexion of the first ray with etiology or pathomechanic factor of the hallux limitus. The results we obtained in metatarsophalangeal dorsiflexion in the study group present more relationship with less plantar flexion of the first ray than to have more dorsiflexion. These results support the theory that in a propulsive phase, we need a correct plantar flexion of the first ray to obtain the dorsiflexion in the metatarsophalangeal joint. We can consider as limitations that the sample size was small, that there have only been included patients with normal first ray and with hallux limitus, and in future research, we can include patients with other pathologies. And the conclusions were, 1, in the participants of this study, it was observed that subjects with hallux limitus had more dorsiflexion and less plantar flexion than normal subjects. 2, the total range of motion of the first ray was very similar in both study groups. And 3, the correlation between the plantar flexion of the first ray and the metatarsophalangeal dorsiflexion was moderated and direct. Thank you for your attention.
Thank you, Priscila. Do we have some questions in room 1?
No question in the room
Do
1.
we have questions here? I have a little question. Were the researchers blinded? So did the researchers know when they were measuring the mobility? So did the researchers know if or which patient they have in front of them when they were measuring the mobility? So did they knew that it was a control subject or a subject with hallux limitus?
Yes, they know it.
Okay.
It's not blinded.
Okay. Perfect. Okay. No other questions? Okay. Thank you, Priscila. All right. Okay. Ciao. Hello. Hi.
Hi.
Are you going to
Can you
introduce our next
Yes.
speaker?
Yes. We have the next speaker, Marta Moreno, Fresco, de la Universidad of Seville, and his speech is about strengthening the peroneal longus in subject with flexibly dorsiflexed first ray, randomized clinical trial. Marta?
Good morning, my name is Marta Moreno. I am a student of University of Seville, master degree. Firstly, I would like to thank the organization for giving me the opportunity. I'm going to present a randomized clinical trial about strengthening the peroneus longus in subjects with flexible dorsiflexed first ray. As it is known, during the propulsive phase, the plantar flexion of the first ray facilitated by the peroneus longus muscle PL's henforward is essential for proper propulsion along with the windlass mechanism. We cannot forget that alteration in the dysfunction can result the insertion point approaching in the ground plane, reducing for stability and causing gradual elevation of the first ray. This situation of hypermobility, which will imply biomechanical change and will be responsible of pathologies such as Hallux limitus, Hallux rigidus, flat feet, among others. In case of unstructured dorsiflexion, enhancing the action of the PL with exercises with elastic bands can improve the stability and low bearing the capacity in this bone segment. Regarding the objective, the main aim of this study is to determine whether using an elastic band exercise program for 4 weeks can improve the first ray function in subjects with a flexible dorsiflexed first ray. The sample for this study was made up of podiatric students of University of Seville as long as they met the selection criteria and agreed to participate in the study voluntarily during 2022-2023. The inclusion criterion was to present a flexible dorsiflexed first ray, while the exclusion criterion were the next ones. Having suffered for trauma that could affect the mobility of the first ray, present Hallux Abducto-valgus, first ray surgery, undergoing some orthopedic treatment, and or having suffered systemic degenerative or neuromuscular disease that affect the feet. To carry out the clinical examination, the mobility of the first ray was measured using an instrument to register the range of motion of maximum dorsiflexion. The head of the first metatarsal was moved upward and downward to its maximum range in plantar flexion and dorsiflexion. The range of motion was determined by observing on the instrument rulers how many millimeters it moved in both positions. With the subjects who met the inclusion criterion, the other parameters were explored. First, metatarsophalangeal joint dorsiflexion with the goniometer, foot pusher index. For excited by the first metatarsal, a specific muscle examination of the PL was performed with a dynamometer. Plantar pressure of the first ray were measured using foot cams. Now, let me focus on the PL strengthening program. The intervention for experimental group consisted of performing a series of exercises of 3 sets of 10 repetitions 3 times a week for 4 weeks in a sitting position with the knee flexed at 90 degrees. They performed the version movement on the foot with depression of the first metatarsal head and a slight plantar flexion. To control that the exercises were carried out, the study group participants were phone contacted to remind to do the exercises. How the data analysis is carried out? The statistical analysis consisted in, on the one hand, for descriptive analysis, it was used the absolute frequency, relative frequencies, median, mean values, among others. On the other hand, the use of normality tests were considered to determine whether the data follow a normal distribution and to know if comparison should be made using parametric tests or non-parametrics. All this by using the software package SPSS. The sample for this study consisted of 32 feet of 24 subjects, 16 in the study group and 16 in the control group. 21 left feet and 11 right feet were included. Regarding the methodology chosen for this study, we used the exercises with elastic bands. Although there are no studies demonstrating effectiveness in this muscle, there are investigations with positive outcomes when used for lower limb strengthening and ankle stability improvement. Additionally, concerning other types of exercises to increase PL activity, which cause muscular habituation over time, we think this type of strengthening could be more effective. The decrease in the first variable may be due to the exercises helping to improve the functionality of the first ray. Regarding the second variable, the increase may be because if the first ray is dorsiflexed, when the foot pronates, forces are transferred towards for the medial far foot for a longer period. Finally, muscle strengthening reduced the luring time during the stand phase, bringing the moment of maximal load closer to liftoff. Now, let's see the significant differences in the control group. They only were obtained statistically in the metatarsophalangeal dorsiflexion, although it increases within that this difference of 5.6 degrees is low, because this measurement was obtained with the two-branch goniometer and the values are marked each 10 degrees, so that it doesn't present clinical significance. Regarding the variables measured with the pressure platform, the control group obtained significant differences in those two variables. However, in both cases, the variables decrease in values. We think this may be due to the small sample size used in this study, as this subject didn't undergo any treatment that could influence these changes. Although the result of the dorsiflexion of the first ray were statistically significant, they weren't considered relevant due to similar differences observed at the beginning of the study. The results should be interpreted with caution, as an increase in the sample size could homogenize the groups. On the other hand, regarding the plantar flexion at maximum pressure of the first metatarsal, the study growth showed significant improvement after 4 weeks of training compared to the control group. We believe this may be due to improved functionality of the first ray in both static and dynamic conditions. Conclusions. In this study, it was observed that the subjects who performed an exercise program with elastic bands to strengthen the PL muscle after 4 weeks of training presented 1. An increase in plantar flexion of the first ray with a 30.69 millimeters of improvement more or less. 2. An increase the pressure of the first metatarsal head during the stand phase of the gait about 4 newtons approximately, and its maximum pressure in dynamic about 9 newtons approximately. 3. A slight increase in the percentage on the time interval in which this maximum pressure occurs during the stand phase. 4. And a decrease the percentage of lowering time during the stand phase about 3% less. So that all is a bit a pressure to show our result in this Congress, and thank you very much for your attention.
Any question? Here we don't have one question.
Are some questions here in?
Here one, just a minute.
Sorry,
One question
sorry.
here in the room one, just a minute.
How many weeks do you need to resolve the study?
It needs 4 weeks, according to the evidence.
So 4 weeks of exercise to improve the strength. 4 weeks. Yeah. 4 semanas para mejorar. Yes. Any question more here?
Hi.
Hi,
Excellent
Alfred.
presentation. Very well. Well done. Can you please describe to us how the strengthening exercises were performed? For those who are not familiar with this. How the strengthening exercises were performed. The protocol. With the elastic band.
Es que no sé responder.
Dile que...
¿Responder en español? Vale.
Que estamos haciendo la traducción. Alfred.
I hoped it wasn't a difficult question, so...
No. Gabi is doing well.
Okay, Alfred, in this case is that in inversion, he put the foot in this position and do an inversion with the dorsiflexion of the plantar flexion of the first ray. Okay, and with this move, with the elastic band, can move around this. Okay,
Right. And you hold it
It's
against
fine?
resistance, right?
Okay.
Yeah, yeah. Cheers. Thanks.
Okay. Welcome.
Kevin, you can.
Yep.
Yes?
Go ahead, João, no problem. Our next speaker is Manos Arvanitakis from Mitropolitiko College in Athens in Greece. He will be presenting a topic which is called the effectiveness of an innovative Hallux Valgus sock on dysfunction of the first ray and Hallux Abducto-valgus progression in athletes.
And welcome, Manos. Welcome to you in Empode.
Good morning, bonjour, kalimera. Thanks very much the Empod family that have me here to present my PhD work. My name is Manos Arvanitakis. I'm the president of Greek Society of Podiatrists. I've been working with athletes for the last 30 years. I was an assistant of the podiatrist, assistant podiatrist for the Manchester United Football Club in England. And now the 2 years, I work with many teams in Greece, football teams, and with very famous athletes as well. And by now I'm working for a football team, Athens, that we won the Champions League last year. And we are hoping that we are going to win this year as well. And you cannot win the Champions League without a medical team, as you can see here on the picture below. As we all know, athletes are susceptible to developing problems because of speed, intensity of play, the starting and stopping nature of sport, type of shoes to wear, acute injury, chronic and repetitive stresses, improper care, and infection. The first ray, and I was impressed today that we have an extra session for first ray, because we've been researching that there's a big gap by lots of people not researching the first ray, but I was happy today to see the session for first ray. And comprises of the metatarsal and the first cuneiform bone. The role of pronation of the subtalar joint is the lower of the first ray to ground in order to disintegrate and absorb the heel's impact. Thus, the medial longitudinal arch becomes stabilized through supination, hence preparing the foot for phase of propulsion. Dysfunctions in the biomechanics of the first ray, such as hypomobility and hypermobility, have been suggested to play a key role in an amount of foot conditions. And as you can see, I'm always with football players. And Neil Blitz has been convinced that hypermobility is the real clinical problem in approximately 80% of patients with first-ray disorders, such as bunions, flat feet, hammer toes, and forefoot overload. I'm a firm believer in the early intervention and prevention of complications. This has been my main reason for developing the Hallux Valgus sock, an innovative product with a patent diploma and protocol approved by the National Organization for Medicines and certified by GDM. This product controls the first ray, reduces foot pain and instability during walking, helps post-surgery rehabilitation of the bunion, and reduces the risk of bunion recurrence. This is the diploma of patent. I was very lucky to meet these wonderful people in Romanian Congress, in the Podiatry Congress in Romania in 2019, and helped me to decide to do my PhD work on this area that I love to work with. So this is the main Cynthia Formosa, my professor, co-supervisor Alfred Gant. It's very nice to work with them. This is the main reason that I want to scientifically test the Hallux Valgus shock, to offer a novelty of the Hallux Valgus shock and to offer a novelty of my PhD. The Hallux Valgus is a progressive forefoot deformity which manifests by a lateral deviation of the great toe at the metatarsophalangeal joint. This condition may as well result in the prominence of the first metatarsal head along with overlapping of the first and second toes. This you can see then deviation. And you can see there how the high pressure can affect the feet, and can you imagine that with the athletes? Hallux Valgus angle from lumbar to severe. Surgical intervention should be the last option for patients presenting with Hallux Valgus, and especially for athletes. If you work with athletes, you can imagine that. You can tell them to go for surgery because it's very difficult to decide to go for surgery. So we have to find different ways. Many conservative non-operated treatments have proved insufficiency. Therefore, there is a scope of innovative non-surgical option to reduce Hallux Valgus development and support proper foot function. And as can you see, the gold standard surgical procedure that the foot and ankle surgeon and podiatric medicine surgeon, they provide the stability of first ray, the limitus method. So that's why it's very important to control the first ray. This project aimed to investigate the effect of innovative Hallux Valgus shock on the first ray and first metatarsophalangeal joints, kinetics, kinematics, and muscle activity related with these joints. Findings will be correlated of these joints function in relation with Hallux Valgus progression. The overarching aim of this PhD is to provide the insight of whether an innovative management option of Hallux Valgus and Hallux Valgus shock will affect the function of first ray, reduces the progression of Hallux Valgus, and favorably alters pressure under the foot, and its effectiveness in relieving the patient from pain, discomfort, and possible resultant disability. This process comprised of 4 different phases. First phase was the systematic review that we have already done, and we published a paper as well. Second phase was finished. I'm going to describe about the second phase in the other slides. Third phase is in progress, but we are near finish. And the fourth phase is development of protocols for the use of innovative Hallux Valgus shock on pain, foot function into clinical practice. We've been to the PubMed and we found like 68 references related with our work, but we end up with 8, which is included in qualitative synthesis. Phase 2, this phase was divided into 3 separate pilot laboratory-based studies in order to investigate the physiological effects when wearing the innovative Hallux Valgus shock. These pilot studies were conducted at the Clinical Biomechanics Laboratory, as you saw the picture before from Alfred, at the Faculty of Health Sciences, University of Malta, on 12 representative participants who met the inclusion and exclusion criteria. Lab test analyzing motion capture, electromyography in order to investigate foot function during gait with and without wearing the Hallux Valgus shock. This, you can see the Desley's miniature imaging sensor, and you can see the reaction of the abductor hallucis muscle movement. Lab test utilizing foot pressure mapping in order to investigate plantar pressure distribution during gait with and without wearing Hallux Valgus shock. The anatomical sign that we work on was first hallux, first metatarsal, 2 and 4 metatarsal head, and 5th metatarsal, with and without wearing the sock. Laboratory photographic measurement of Hallux Valgus angle. The results were great. We found that on the both feet, the hallux pressure was reduced by using the Hallux Valgus sock. Also reduced on the first metatarsophalangeal joint on the both feet by using the sock. Also reduced on the 2 and 4th metatarsal head on both feet by using the Hallux Valgus sock. And less reduced on the 5th metatarsophalangeal joint on the both feet by using the Hallux Valgus sock. Foot and angle measurement on by using the Hallux Valgus sock was actually reduced. Mean degrees was in 4.19 degrees. We had good movement by using the sock and increased the activation whilst wearing the Hallux Valgus sock by using MEG sensor. And phase 3, this study comprised a randomly controlled pre-post intervention design. Will investigate the efficacy of the Hallux Valgus sock on 50 subjects presented with Hallux Valgus. When compared to another 50 subjects, we will act as control. This study is currently being conducted in Greece, and we are very near to finish. In this phase, I'm going to present next year in Madrid the results. This clinical trial is being conducted on 100 subjects presented with Hallux Valgus, 50 participants assigned to experimental group, and are being provided with Hallux Valgus innovative sock being tested in the research, whilst another 50 participants are acting as control group and are receiving standard care for Hallux Valgus, which is usually given to patients in private clinic, including advice on footwear and amongst others. At the end of this trial, after 6 months, results between both groups will be compared to evaluate whether the use of Hallux Valgus sock positively impacted foot pressure, distribution, pain, and quality of life. Finally, the phase 4, development of protocol. In this phase, providing the positive outcomes are achieved during the phase 3, protocol will be devised. This protocol will include instruction on how often the sock should be worn, very important, in order to achieve improvement in Hallux Valgus angle, reduction in pain, and improvement quality of life. This project will serve as a stepping stone to shed light on new information penetrating to use of the innovative Hallux Valgus sock as possible alternative to surgery in treatment of Hallux Valgus. The value of the sock is that it strengthens the abductor hallucis longus muscle, which is very important for the foot to have a strong abductor hallucis longus in a non-invasive manner, thus serving to control the position and function of the hallux and transverse plane. This project aims to improve the knowledge and the skills of researchers, and in the future various clinicians who could start using the innovative device in their clinical practice in the management of Hallux Valgus. Also, it will integrate clinical practice and patient management with new medical device for the market. The device could highly encourage both clinicians and patients to make use of such a product, which could hopefully lead to relieve patients pain, discomfort, and disability which are known to occur with progression of Hallux Valgus. This offers a novel alternative to clinicians and patients in the management of Hallux Valgus. This process will inform future studies on understanding the mechanics of the prevention and management of this very common musculoskeletal pathology. It will fill the gaps for innovative approaches for the treatment of Hallux Valgus, hopefully offering long-term relief to patients and furthermore offer correction in its pathology, especially if managed in its early stages. of development. And don't forget that good health starts from healthy feet. Thank you very much.
Any question in the room 1? One question here. We have one question here in the room 1.
Hi. Okay.
Hello. I noticed that in the phase 4, you said that the research have been done with the customer feedback loop. Then what was the outcome? How often the soak should be used? Like when you said that you have done with the athletes, so they have very intensive training, I suppose. And is it influenced? Like, is it different like sport? They would have like really like, do you recommend them like how long to use the soak? And also the footwear. They have very tight footwear, like you said, for football player. Does influence when they use the soak and also the footwear, or they use the soak without the footwear, like with only the training? Do you make the comparison within the training, like when they really match, or the just sporting, like for training? Do you have the outcome already? Can you give the comment?
Very good questions. Yes, because you have different parts from your question. The thing is that we don't have already done the protocol because it's the phase 4, because we have to see all the data from the questionnaire that we are doing to our patients. But the thing is that because I'm using the long time with my athletes, and especially with a football team that I'm living with them, I'm working with them very specifically. Like I'm not extend the use of the sock. I'm trying to let them use the sock for only an hour per day to strengthen the muscle, like to exercise the muscle. And especially for athletes, because you know, if you are working with professional football players, it's something very difficult, because you have to see lots of parameters with them, because you know, the money are a lot, the pressure is a lot, so you have to think by doing things with them very seriously. So with my athletes, and especially with football players, I'm trying to control the first ray specifically when I want to control the first ray, to say to them where are the training, and come after the training to see how you're feeling. We have to do very careful movements with them. But after we finish with the data, so that's why I'm saying that we are going to present next year, we'll have all this data collection from 100 patients, and we are going to see actually what we are going to see, to make the protocol and to use some guidelines about the use of the sock.
Can you say exactly how long they have using, like 1 hour approximately, or 15 minutes?
We suggest to our patients, and in our clinic as well, not in athletes, to use it for an hour.
An hour?
An hour,
okay.
just to strengthen the abductor hallux longus.
Okay.
But if some patients feel comfortable to use it more, it's up to them. But the guidelines from podiatry view is just an hour by walking, not just sitting.
Okay. And the product patent is in whole European country, or is international like patent? You said that your product have already patented.
The patent is European.
Patented. Yeah, okay. Thank you.
Thank you very much.
We have here one question in the room 1. Just a minute. Gabi?
Okay, I understand that it's a cross-sectional study, no? It's a transverse study, not a longitudinal study, I understand. So, do you think to measure the effect in the long time? So it's 1 year, or that during the different timeline. So, for example, 6 months, 1 year, 2 years, because at the end, the best of this element is to analyze in the effects in the patient during the using times. So, but I don't know, you think to continue with the longitudinal study?
Yeah. Yes, we follow that for 1 year.
So, how do you control this? Because the problem is the add to this treatment. So, how do you control that the patient use it during this year? You understand my question? So, the patient will use this shop during times. So, but the most problem can be the use when, because the add to this treatment sometimes it doesn't like the insult. So maybe the people don't use in our area, the Mediterranean area, for example, with the hot in Spain, for example, in summer we don't use a lot the insult. So I don't know, it's this limitation you are control.
You mean in our research in general? In our research.
In general.
No.
No.
In our research, you mean? Because the phase 3 that we are running at this moment is we are studying our group that they are using the shock for 6 months, like 0. They come to our office and we measure all the parameters, and then we see them after 3 months again, and we see them again after 6 months. So we come up with some data, and the guidelines that we give to them is use the shock for an hour. Yes, because we say to them to use the shock, so we trust them that it's very easy to use the shock for an hour. So, but the results that came up to us after approximately 6 months up to April, that we finished the 6 months to the whole group, seems that there are very good results.
Continue to follow your work. I like it.
Thank you. Thank you very much. Merci beaucoup.
Any question more here in the? No, Kevin, here in the room 1, auditory 1, we don't have more questions.
No, I don't think. Are there any questions here? No, I think it's okay.
Lunchtime.
Perfect. So now it's going to be lunchtime for everybody. Just wait for some information about this. Eleonore, please.
Yeah, we have just some information. You will find the lunch bag, where you had coffee during the coffee break. You can grab it and go eat anywhere you want.
Okay, it's so noisy.
Come back here for.
So noisy, so I say it again. Okay, the lunch bag are available in the sponsors' rooms. Okay, you will find lunch bag for everybody to have a little lunch, and you take it in the sponsors' room. Okay. Eleonore encore.
It starts again at 1 o'clock and 10 minutes. And don't forget the contest. Vote for your posters and answer the sponsors' questions. So you
don't forget the student test, the student contest. Okay, and you have also the sponsor questions contest. Okay. Have a good lunch. Thank you very much.